I can't think of three better people to tackle what the last panel teed up, but at a very let's get real kind of, like we're just going to be very honest, including I think where there are just I'll be the person that kind of vocalizes God, what are we doing? Some days I wake up and I'm like, what are we doing? So how we can get there. But I'm really excited because the District of Columbia, the home we're in, I've now been a resident of DC for 15 years almost. And in a way, I think Dana's so eloquent. She put it best that we're not very connected. And so part of what I'm very grateful for is that as a clinician in the District of Columbia, I started noticing over the years that I just really saw this lack of connectedness result in really, in my little neck of the woods, really severe healthcare problems. I see people in an ambulatory primary care clinic setting, and I really struggled, and I even told Paula, I'm going to introduce people briefly, but I feel like these are friends. I would talk to each of the people, in different ways on this panel about the struggles, and I'm very thankful to the Aetna Foundation because, to be honest, without kind of this public-private and intersection of philanthropic support from the District of Columbia, support from even our own hospital at Johns Hopkins, I honestly couldn't see a way forward to try to bring a community together. And I'll just start. What I want to do is just make sure I introduce each of these people. They have their formal titles. I will read them because that's important. But I'm going to tell you just a little bit about each one of them, something that you probably wouldn't have necessarily guessed from their titles. So I'm Kavita Patel, you all know me. And then starting at your left is Paula Reichel. She's the Advocacy and Nutrition Education Director for the Capital Area Food Bank. But what I will tell you that title does not speak to is that Paula is truly one of the connectors, not just in DC. I'm going to let her talk about the Capital Area Food Bank, but she is one of the connectors in such an important way in a very large geographic region for Maryland, DC, and Virginia. And one of the few women I know, very young, but so mature in her years, because she really does bring kind of all of these complex thoughts and hard questions into a very practical way of thinking about food insecurity. And I will tell you, if any of you are family members, parents, loved ones, once you start kind of talking about someone being hungry, that's where the conversation stops. You can't talk to them about anything else because that feeling of gnawing, that hunger overrides everything. So Paula's truly a hero in my book. Matt Brown, who also has a very nice title, Geriatric Nurse Navigator at Sibley Memorial Hospital, does not do him justice either because he's one of the people in a hospital-based setting who is what I would argue leading kind of this call to doing better in the community. And he, whether his colleagues like it or not, pushes the limits on how we think about not only transitions out of the hospital, but how we really think about people honestly staying out of the hospital and doing it in a way that gives them the best chance at productivity. And I can truly say Matt is kind of helping to step in for a community partner who had to actually do some work with the District of Columbia around aging. And so Matt, who is a geriatric nurse by training and actually practices this in a daily setting, Matt is going to speak, I hope, to what he and I overlap in working in the District of Columbia and trying to understand how does the hospital play a role. And then also pushing, he and I can speak very honestly, I can, because I'm not afraid of any of my superiors. I mean, there are many days where I go to our CEO of our hospital and tell him he has to do better. I mean, it's not acceptable for me to see, millions of dollars in hospital budgets, be they for-profit or not-for-profit, and then one small, infinitesimal, minuscule portion of that goes into the community. So that's not acceptable. Our CEO at Johns Hopkins agrees that it's not acceptable, but then getting that translated to the CFNO and the other C-suite leaders is absolutely what makes Matt and I, that's our daily living, right, Matt?
You see the camera. Right?
I do see the camera. I'm not afraid.
I'm just kidding.
There's something that comes with a little bit of age where you just don't care anymore. You're just I'll have a job somewhere. Someone will hire me. It's okay. I'm not afraid to speak truth to power. And then finally, so Adrian's title also, it's very fancy, Executive Director of the District of Columbia Housing Authority. What the title doesn't necessarily convey is that Adrian is probably one of the few people who also, she sits in these healthcare conversations, she's patient, she kind of stomachs this, and she is kind of like itching to kind of burst out of the gates to really talk about not just where housing kind of has a role in all these things we're talking about, but how much she's fighting in the kind of silos of housing policy to do exactly what we're talking about. So all these same conversations, as Stuart kind of mentioned, are the ones that you're having as well. So the one I just want to do, in the District of Columbia, there's so many things going on, but one of the things that we're working on is actually kind of trying to connect, and then I'll tell you a little bit about this to tease it up, but then I'm actually going to start with Adrian and kind of work our way down. One of the things that we're doing in the District of Columbia, kind of with the support of the Aetna Foundation, has been to actually try to connect community partners. One, it's really to focus on high-risk populations. And I'll tell you what's interesting. When we went out and tried to talk to people about what does, quote, high risk mean, it was very fascinating to listen to people of very different backgrounds talk about things, including patients. We asked patients, like, do you think that do you feel like you're worried about your health care? And what was very interesting is kind of the different responses we get. Well-validated literature, and what I used to start the conversation was if you've been in the emergency room or if you've been admitted, and Matt and I kind of start with those conversations because we see people being admitted to the hospital. We see people going to the emergency room many times. Interestingly enough, though, patients and community partners identified things like loneliness. If people feel lonely, people feel worried that they're going to die in the next year. There were a lot of things that people identified themselves that classified them as high risk that our conventional medical literature wouldn't have even put into a journal. So we are learning more, and what we're hoping to also kind of really embark on in this next phase is how to do the reverse. Paula and kind of some of the other partners, we've talked about flipping the model a little bit, because as Stuart mentioned, his mother in the post office knew more about what happened in people's health care or in their daily lives than any doctor ever could. And so when we get to Paula, I'm hoping she'll touch on the fact that they're going to be hosting the Capital Area Food Bank as a community partner. They're hosting kind of this Health and Hunger Summit next week, but they're also trying, and I'll be honest, I've worked with her field coordinators, and they do a much better job identifying who they're worried about that might be, quote, high risk, but I would never have seen them, and they might never have had an access point with a conventional medical institution. So we're trying not only to kind of do things better in the healthcare setting, but we're trying to flip that and have the community partners really identify where they can help to, you can call it hotspotting, health compass, some way of identifying kind of what's vulnerable in your communities. So let me stop there. Adrian, there's so much to kind of touch on. First, just tell us a little bit about kind of what you're doing from this framework of housing, and especially educate our audience. We've got a lot of smart people here, but educate us a little bit in kind of some of the constraints you find in DC housing and where you see some of what we talked about in that last session kind of coming true to what we're doing in the district.
Sure. Good morning, everyone. So as a houser, we really focus in on the built environment, and things like working with healthcare institutions comes as cherry on the top of the cake. But we think about what is our responsibility to a healthy neighborhood. And we were doing this way before neighborhoods became sexy again in the past 3 or 4 years. Like way back in the 90s, we began to look at our public housing communities as being unhealthy for a variety of things. Not just the lack of access to amenities and good health care, but just the built environment itself, the units that people were living in, and also just what it meant to have a socioeconomic group that was impacted in terms of just the level of poverty there in the neighborhood. So we began to look at our communities differently as housers, not knowing that our end goal would be building healthy neighborhoods. Mm-hmm. We just needed to fix the units. And what we found from that work in the late 90s to today is that smart researchers have now followed a lot of our work and said, wait a minute, neighborhoods matter. Look at what happens when you take an impacted community and you make it mixed income and you create different amenities for the neighborhood. We have a great site here in the District of Columbia named Sheridan Station, which is in Ward 8, which was a really dysfunctional public housing site for some time. Not the people, but the units were just falling apart. And then we redeveloped it, and today it is a thriving 300-unit community. We brought back many of the families that used to live there. We have a clinic on site, but what we've created is a place where people are not afraid to bring their friends. The pizza people will show up. And it's really created a much more healthy environment. And as a houser, that is just one strategy in terms of creating healthy communities. We have two other strategies that we use. The one that many people in this room is probably familiar with is how do you institute a mobility strategy for families? If the neighborhood is unhealthy, how do you move people into healthier neighborhoods? So one of the things that all housing authorities do, we're very fortunate to be able to toggle between creating a place-based situation, but also a mobility initiative. So we have our housing choice vouchers. And here in DC, we're very, very fortunate. If you're a local DC person, we also have a local voucher program that we should all be very thankful about. And in those programs, we are able to move families from neighborhoods that they don't want to live in into other neighborhoods that may have stronger schools, better amenities, and better social networks for the family in terms of where they want to, the trajectory that they want their kids to go. But it's very expensive to do that.
Yeah.
That's a very expensive strategy. And even here in DC, whereas HUD will give us what's called a payment standard of fair market rent of 100%, here we've had to push the value of our voucher up by 75%. So that we can afford even the neighborhoods that we were once in 10 years ago. Shaw being a great example. Yeah. So while these strategies all have different value orientations to it, some people feel like we shouldn't be moving families out of their neighborhoods, that they should be able to really invest in the current neighborhoods. We're also invested in neighborhoods, but they all cost money. And we can talk about a little bit later about what that means for all of us in this room for being ambassadors for affordable housing.
Right, because to be pragmatic, there's hard choices with that. I mean, the money is actually there's right. Real serious budget issues right. that are causing you to have to make decisions, obviously. And so, we'll go through everyone, but I just sure. want to plant for you kind of thinking about, we had this conversation about healthcare resources. Have you, in a time of really honestly creative budgeting, thought about what does this mean if we think differently about healthcare dollars and allocations of resources? So I'll let you think sure. about that. Matt, go ahead and I'd love for you, if you don't mind, I know that I set this up in many ways. I would love for you to just talk a little bit about the work you've done and thinking about not just the hospital serving kind of as a little bit of a hub, which we referenced in the last session, but also kind of what could hospitals be doing better? What do we need to do a better job at doing in thinking about kind of this notion of communities, connectedness. And then I know Matt's gone into, Stuart actually didn't realize this, he set it up pretty nicely. Matt's actually gone into patients' homes who have kind of been discharged and give us a little flavor of what those insights have given you and kind of what we can learn from that.
All right. Thank you for having me. I have celebrating 10 years as a nurse today, and I've got an award reception tonight, so getting to knock out two occasions in a suit and tie when you're used to working in PJs.
I know, I never see him in a suit.
She's giving me a hard time.
I almost didn't recognize him.
Yeah. But with the pajama comment aside, I am honored to be a nurse and be a part of a really special profession, and with a microphone and with an audience, I will say, applause for nurses, because it's
that's right.
I'll clap for that.
Grateful to be a part of it. To your question, I've done not as many home visits as I've done follow-up phone calls. And when Stuart was talking about the fall, I will never forget, and I bet I've told this story a dozen times, but the very first follow-up phone call I made was a guy that I'd gotten to know for a week in the hospital, and I was checking in on him at home, and I called him, and he's hemming and hawing on the phone a little bit, and I'm like, Bob, are you okay? Is everything all right? And he said, I think so. I said, you think so? What do you mean? He said, well, I fell. I'm like, oh boy. So I'm a nurse, falls are obviously terrible. And he said, well, I'm not sure because I'm still on the ground. I said, good Lord, Bob, you got to call 911. He said, no, my wife will be home in a couple hours. I said, is she going to be able to pick you up? And he said, no, probably not. And I said, well, you got to call 911. He's like, and he's back and forth with me because he didn't want to come back into the hospital. And we ended with, I said, is the door unlocked? He said, well, no. I said, so they're not even got to kick the door in. They'll come in, pick you up, dust you off, check your vitals, and be on the way. And I said, and if you don't call, I'm going to call 911, and then I'm going to call your wife.
Right.
So he did, and actually called back and got to speak to the EMTs and make sure he was okay. But in that example, that first call, I learned that people don't understand the severity of that time when you're discharged to home, how much can go wrong, and how on high alert you need to be. And then in a home visit, would go with our former head of the hospitalist, and we're in the home, and the guy had gotten his meds filled, which that right there, people can't always do that, but he had his medications, and they were on the table, and he was on the exact same drug, same pill as his wife, and the pills are like right here, and all it takes is one cat walking by, and they're mixed up, and he was able to show us and talk through, but he had it by bottle, so we had to spend some time with him to educate him on we need to space these out and separate them and make sure that he understood the severity of taking the meds. And I think nurses would tell you we could do better at discharge from the acute care setting to home to do that teaching. And they would also be quick to tell you more nurses would help with that. I'm not up here to talk about nursing shortages or fix any of that, obviously, but I think the other thing we run into in that transition from acute care to home is as soon as people hear discharge, they're gone. Their readiness to learn is not there. They're cleaning their inbox, they're getting groceries, they're not ready to listen. So I think we need to approach education from a multifaceted, multimedia, meet people where they are, where they're ready to learn. And we know the best discharge starts on admission, but we also know that you start talking about discharge too early, you can get people wound up, they're not ready to go home. So I think we need to be meeting them where they are, whether it's one of the things I'm working on at the hospital now is getting patient education videos sent to patients on their email so that they could watch them when they get home or they could watch them prior to their surgery. And I think just trying to have things in place like to catch them, whether it's a phone call, whether it's we're sending them with an iPad to FaceTime with somebody, or ideally you have them enrolled for that 2 weeks in one of the villages and somebody's able to pop by and put eyes on them. Just have them be caught, because I think people don't realize how critical that time is and how much they really need to be on higher alert.
Can you talk about what the villages are, just because people might not know?
Oh, sorry.
Just a very brief description, because I do think it's a good example of where communities have come together, especially in the district, kind of truly on a voluntary basis to help out. But then what's they're what the hospital does to be a part of that.
They're based on neighborhoods, and so it's networks of volunteers, and there's a paid person who sort of coordinates all the services, but based on your neighborhood, you can pay a subscription fee, which helps maintain the organization of it. And then you can get not necessarily clinical things, but like a light bulb change, a trash taken out, somebody to drive you to medical appointments, like a nice non-clinical neighbors helping neighbors. And it's awesome. And I wish they were bigger, and I wish we could. And
we've been paying, so just to be candid, because it's not, I forget the amount because we pay for it, but it's something like, I want to say, $50 a month. But we know that there's no amount that's an easy amount to pay, especially when you're living on that margin and it's making a decision to pay your electricity bill or to be a part of a village. So the hospital and actually our clinics were subsidizing kind of memberships into the villages so that people can have access to transportation and some of these other, and to help fix, like Matt's example of the light bulb is a very common one where people just need help around the house, and that poses significant barriers. So I highlight that because it's a really good example of where both philanthropic dollars, hospital-based resources can be allocated for a community-based resource that helps bring connectedness within like an actual neighborhood. And so that's one of the models that's kind of a nice example. I, as the finance kind of healthcare person, try to think, how do we find a sustainable way to integrate that into the way we pay for healthcare? So we're doing this right now on the backbones of nonprofits, philanthropic organizations, and the hospital, but how do we actually create that into like the bundled payment for orthopedics or something like that. So thank you, Matt. Paula, so I've set it up for you to close out this all-star panel a little bit, but first tell us about the work you're doing, and then really drive home, I think each one of us are trying to bring it back to something local. Really talk, I mean, you educate me constantly on just how hyper-local all of this is, but talk about food insecurity and then this intersection of health and hunger. And plug your summit, please.
Oh, you're so wonderful.
We're 100% going to make sure people are going to be a part of that next Thursday as well.
Thank you, Kavita, and thank you for that lovely introduction. When I'm having a bad day, I will reflect back on that.
Just watch the webcast over and over again.
So I am a part of the Capital Area Food Bank. We're the region's largest anti-hunger organization. We reach 540,000 people across the metro area. That's 12% of our region's population. So just to give you a thought about and some thinking around our scale. And we reach them with 46 million pounds of good food. And I'll come back to that idea of pounds and why that's such an important inflection and reflection point for us. But we're essentially a neighborhood-based organization, and we're rooted in the community through our 444 community-based nonprofit organizations. And those organizations are the ones who access our food, distribute it, have those local relationships, have those neighborhood-based relationships. And most of them are small, volunteer-run nonprofits. So we're not talking about like high-capacity organization. We're talking about like a very committed church volunteer and a couple other folks who run a food pantry every other Sunday, maybe 2 weeks out of the month. So that forms the basis of how we operate, and when we don't have a partner, we look to place targeted direct food services into the community. And so as an institution, we're well over 30 years old, but we don't look it. But for our entirety of our 30 years, as well as the majority of the nation's 200 food banks, we've been driven primarily by one metric, and that's output in terms of pounds of food distributed. But we know that not all pounds are created equal. Soda is a lot heavier than leafy greens. I know because we actually harvested 2 pounds of leafy greens out of our garden just the other day, and to think about how much is 2 pounds of leafy greens versus maybe a 2-liter bottle of soda. And so knowing that, and also knowing the rate of incidence of chronic disease in our community, high rates of diabetes, high rates of heart disease, high rates of obesity, and that food can be a solution, and that food can be an equalizer for members of the community. We've really stepped up and evolved our approach into what we're calling 21st century food banking. And 21st century food banking is where we address hunger needs while also improving the health and well-being of the communities we serve. And so we've gone through this process and evolution in our thinking about how we operate. And I just want to walk through the steps a little bit so you get an idea of how this looks like on the ground. So the first thing we did was we really bought in all members of our constituencies, the people we serve, the organizations we work with, and most importantly, our food donors. So we really wanted to turn the myth on its head that food donors just perpetuate the problem. We've actually been able to engage them to come up and join us on our path toward a more healthy, well community. So they're a part of the solution. So another piece of how we've operationalized this is by focusing first on what we do, which is food acquisition, food movement, distribution, logistics, all the things that are not quite as sexy, and a lot of it is behind the scenes. And so to do that, we actually had to start from scratch and say, hey, what's in our inventory? We distribute 46 million pounds of food per year. What is the nutritional quality of that food? And we actually had to come up with a wellness tracker. Our in-house dietitian developed it that looked at the amounts of sugar, salt, and fiber in our foods. And we're able to categorize our food as wellness or non-wellness. And that was really critical. That was just a few years ago where for the first time we knew the nutritional quality of our inventory, and that's enabled us to really set goals to improve that quality and to have frank conversations with food donors. We've also rethought nutrition education. So in the past, nutrition education is, your 6-week classes where you're engaging a small targeted group of people. You're having a major impact in your lives, but you're asking for a big commitment. And so we really, knowing our scale and knowing what we do best, wanted to refocus our nutrition education around how do we shift and improve health behaviors for folks. How do we send out a pound of food, but we also send it out with key messages that help folks transform that pound of food into healthy, affordable meals for their family. And so, I like to give the example of a banana. It's great to know how much potassium is in a banana, but is that really going to make a difference to your everyday life? No. Well, I want to know, how do I store the banana? How do I maximize its shelf life? Maybe what are some great recipes to use bananas in a savory way for my family, or turnips, or other fruits and vegetables that we may not be familiar with? So that's where we focused our energy around nutrition education. And finally, and I think this connects more to what Kavita is mentioning and this sort of the context of this panel, we've come to the realization that we can't do this alone. Even though we are a large established network, we are not the only ones who are solving food insecurity, who are improving community-based health. So we've made a thoughtful effort to engage anchor institutions in the community. First, we're engaging schools. So we actually have food services and food programs in 73 schools across the metro region, and particularly in elementary schools where we know parents are most likely to shift their behaviors, and we're setting students up for a lifetime of success. So we're sort of creating and helping to be a part of that, creating their health behaviors. We're also partnering with grocery stores. So we want to build a bridge to retail. 56% of the people that we're working with are working. They have earned income, in addition to potentially using SNAP dollars. So we want to see them be able to utilize their dollars in an effective way in the store to be able to create the most healthful meals for their family. And finally, and this points to what we're talking about next week on May 18th, 8:30 to 11:30. Come and see me if you're interested. We want to crack the nut on healthcare. How do we integrate with healthcare institutions? How do we make food a focus for people who are in a clinical capacity? And, this is such a learning experience for me as well, because healthcare is it's a very complicated field. And so for the past 3 or 4 years, we've just been having frank conversations with healthcare providers and saying, this is the problem. How do you see us working together to address it? And that's taken many forms, whether it be integration in the clinical setting, so sort of having food pantries or maybe food boxes at discharge as a part of a procedure and including a food insecurity screening. Or maybe it's the reverse. Maybe it's embedding health services in our points of distribution. So within our food pantries, where we know the population is not going to see their primary care provider. Maybe they have an untreated, maybe they have high blood pressure and they just don't know. And we actually see that quite frequently. So all of these pieces really come together to help us serve in a way in this connector role to build our network and to focus our efforts around how do we improve the health and well-being of our region's grandmothers, mothers, fathers, children through a comprehensive approach.
And I'll say that some of the things Paul and I have talked about, and I'll just kind of put it to the panel, and then we'll definitely save plenty of time for questions because I know we have them. For example, like that blood pressure screening program, that's something done kind of in conjunction with the American Heart Association. Paul and I have talked very honestly about the fact that, so let's say you do screen someone positive, like, okay, what then? We certainly know that you've got in-house dietitians who have obviously great skills, better than even what I in our medical training and Matt and our medical training have done, but that's maybe not enough. They may need a medical intervention. So part of what Paul and I are constantly struggling with is, okay, so then what's the natural conduit? And one kind of success factor we found is, can people like me or Matt at least serve as almost informational resources for the food pantry coordinators who have the trust and the buy-in from the community member, but don't necessarily want to go to a strange doctor. And I got to tell you, healthcare really, the way we set up our institutions, it's hard. I mean, parking and trying to come to our clinics, and even when they're embedded inside of housing, you have to take time off work because when clinics are only open in the daytime. And so we're trying to struggle with how do we make this accessible? And Matt said it right. It's meet people where they are. But unfortunately, a lot of what we set up ourselves for we don't necessarily do that. So how do we break through those conventions to meet people where they are? And we're trying to constantly think of creative ways to do that. So Adrian, let me come back to you. You touched on, we're in a time of fiscal constraint. I mean, it always feels, I so kind of, I'm sure you're having to go back to a pile of in-mail with how you're dealing with your next budget cycle, how you're dealing with this. Can you, I wanted to pivot this a little bit to almost, if you had your wish list, what are some things you wish you could see, either better public-private sector collaboration, resource allocation, thinking about state budgets? What is it that we could do better?
So I think that, and Stuart said this well earlier, I think there's not a lot of thought about cost savings when we go outside of our silos. So, for instance, it will cost any large urban city roughly between $50,000 to $80,000 a year to shelter a homeless family. It costs me roughly $15,000 a year to house a family. And we keep, as housers, we keep saying that number over and over again, but we hit a brick wall, particularly when it comes to the funders at the federal level, in terms of saying, look, there is a value to housing that is not just about creating affordable housing. There are the other impacts to the rest of the networks that touch a family where we will save funds. And there hasn't been, I think, if I had a wish list, I think the number one thing would be, we have done this great calculation in terms of how to make a more efficient process of moving a family from a homeless shelter into a unit and what the cost benefits are. But we haven't really done that as well in other parts that are costing us lots of money as a community, whether it be healthcare, whether it be a poor education system. We've not seen that kind of thought process that shows if we just do a little bit here, the bang for our buck 10, 15, 20 years from now for the child is going to save us all a whole lot of money at the end of the day. I think that that's a heavy lift. It's sometimes hard because I know if I approach the local hospitals, I say, why don't you just give me some of your money
Now, maybe it'll make a
trust
difference.
me,
Trust
and
me,
you
right.
will save money in the back end. It doesn't go over
Right.
very smoothly. So
Right.
I think that it'd be great to have some. I hate research, but
No,
I
but
love
you need,
research.
it's
but
we need evidence, right?
we need,
reinforce
well, we need
that.
evidence, but we need people to buy into the fact that because it's a zero-sum game,
Yeah.
something has to be taken away
Somebody has
and
to pay
given
for
to
it,
another system. And that is a hard, even if we find the evidence, the question is, will there be a political or even just a will in general
Right.
to do that? Affordable housing is expensive at the front end, but the long-term benefits for a community are just priceless. And I don't think that we think about it that way. We always think about affordable housing as being for somebody else,
Right.
Versus what the community impact would be.
That's a great. Matt, what could, if you had to think about, you're working on transitions, you mentioned kind of videos or, telephone calls. What's on your wish list for some things that we wish we could, that we know we could do better, kind of, for example, in our hospital setting or in that transitional setting?
I think, again, just having things in place to catch people. I really liked Stuart talking about the district nurse. I feel like there's enough with
The analogy of that.
maybe not the 88-year-old I'm sending home that would work. I mean, it would in an actual person, but I'm thinking some sort of an online platform. Like, I live in a townhome community and there's a Facebook group. Like, if we could have a district
Facebook,
nurse,
yes.
The
yes,
Facebook.
the Facebook.
I've joined
sorry.
the Facebook, right? Exactly. Right.
Having-
But is that? Do you find that there's a problem with people's accessibility to media online, or have you found that actually pretty much people are connected in some way? Is that?
But I don't have a firm answer. More are connected than not,
Than
but as
not,
they get
okay.
older, they're
Yeah.
not. And I'm sort of jaded, and that's the population I work with the
Right.
most. But that's getting better and better. And I think of all the boomers that are going to need care and how
Yeah.
connected they'll be, and the
Yeah.
potential that there is for online solutions and online communities, frankly, to help with that. And then I think having a sort of like a massive list of all the services, and I know like Iona's community resource book is incredible, but having like an online thing where if you're in the city and you need help with X, Y, or Z, you can just type that in and find out what would work for you, what's affordable for you, and what sort of options are out there that maybe somebody could be picking up groceries for you once a week, and you don't have to, go hungry or
Right.
have health problems associated with that.
Right. Paula, I'm hoping you're gonna say this, so if you're not, I'm gonna hint to this. You always teach me something, but we talked about kind of your food pantries. I want you to also continue with the theme of a wish list before we get to questions. So think about some of your wish lists, but hopefully tucked in there somewhere is what you told me about how you actually need help getting the food to people, because you can have all these kind of 44 kind of community-based organizations, but you're still finding that one of the greatest challenges is almost the, getting the food from the pantry into people's homes. So tell me about your wish list in a very practical way, and also that problem that you're seeing of getting the food out.
Right. I think my wish list focuses most on how do we create access to good food in every community and for every type of person. And so building on our existing work, it would be to create continuity between these anchor institutions in our community so that we're reinforcing the same messages, so that folks know how to best utilize their dollars, so that we're building access points where they're needed, and that we really have a sense of the need and that we're addressing it appropriately. And that involves a whole lot of shifts and commitments from organizations of all different types, for-profits, nonprofits, government, institutions. And so I think we're seeing those shifts happen incrementally, but to have a community-focused and community-based approach that leads to successful outcomes is my biggest wish. And in terms of sort of the, part of our what we employ at the food bank, actually, we do have some sophisticated tools, one of which is a hunger heat map that shows the gaps in our services. So it assesses the food that we're putting in the community against the need to show gaps. And that gap analysis is really critical. And what we're finding as we're scaling, as food banks are scaling, is that we just have to invest in this last mile work with reaching folks who are homebound, who are disabled, who for some other reason maybe lack sufficient transportation to the grocery store or to the neighborhood pantry. Again, I like to stress, you think about this robust network of 444 organizations, and certainly we have some really key partners who have a lot of capacity, but most of these are, pantries that are open twice a month. So if you can't make it on those twice a month, then you are challenged. So it's about, just making connections, really thinking about capacity and thinking about how maybe hospitals can build the capacity of the emergency food safety net rather than maybe reinventing it within the own organization.
A very real example of this is that our hospital, one thing in the Affordable Care Act has been for nonprofit hospitals to maintain their nonprofit status, to kind of do community health needs assessments. And part of those dollars have to be driven towards actually the community. It's been a great, you can call it a carrot, stick, I don't care, but it's been a great tool to have a conversation and a practical ongoing example. There's mobile vans that are being deployed around the district. I'm trying to figure out how we can actually take these mobile clinic ideas and actually have part of that serve as almost kind of a food delivery service as well. So that's
We're a big fan of Capital Food Bank. I mean, we do our job to try to get food from your part of the world into our 8,000
into the homes,
into our homes.
And a lot of our partners are actually nonprofit housing providers.
Exactly.
So and which makes so much sense, because that's a great example of literally meeting people where they are. Questions so that we can start to get I know this gentleman had his hand up in the last session, so maybe back here. Before we get to your question, I'm going to close by being slightly controversial with my wish list. One, I really do wish that we had a very hard time. We saw in the state of New York kind of the use of Medicaid dollars for housing vouchers, and there have been some very interesting studies, well-validated scientific research that demonstrated kind of the benefits of that use. But certainly that's been riddled with controversy around, is that the appropriate use of Medicaid, state budget dollars? I would absolutely, and I know I'm setting this up hopefully for Stuart's last panel, which is kind of bringing it home, but my wish list is that we do a better job teaching not just our feds, my friends that are all working to try to make this country a better place, but not just how feds can work with state and local governments to think about these creative, kind of, Stuart mentioned this ability for states to be flexible, how we allow for that room for flexibility, but that we don't burden, in doing so, that we don't overregulate it to the point where it crumbles from the weight of all the caveats and regulations and you can't do this and you must do this. Because in some ways, I actually think that's where New York kind of faltered, because there were so many people worried that, oh my God, we're going to let these people get housing vouchers and what's going to happen? And it really kind of crumbled under its own weight in some regards. And it was criticized, but I think it was a brave initiative. And I think that the ongoing need to be creative at that level is going to be, no matter what party affiliation you are, it has to be done in a flexible way. So how can we as policymakers mitigate unintended consequences and hold ourselves accountable without kind of overburdening and inhibiting that potential for communities to design truly flexible approaches to whether it's the Medicaid program with dollars associated with that, whether it's dedicated housing dollars, whether it's SNAP or WIC resources. I would include all kind of government or public-based sources in that. And then I know this is a conversation I've had with colleagues from foundations, and you're going to meet Dr. Graham, and I know he believes this. How do we push philanthropic organizations to think about sustainable economic models for what we're doing? So all of us there was a point where I was like an addict to grant writing, and everything could be done through philanthropic organizations. We have got to turn that into building it into part of our economic model. So in medicine, we talk about a PMPM, a per member per month. How do I get a portion of that, what I'm used to calling a PMPM, to be a part of buying membership for the villages, to be a part of actually giving Paula some of that money and letting her use that for neighborhood dedicated, for her organizations, for what Adrian's doing. And so I would say those are at least two of my wishes. So I'll stop there. And the gentleman back there had a question, and then we'll just open it up to general questions.
Herb Rose. Fiscal concerns have been discussed here at length. Since we have the executive director of the District of Columbia Housing Association Agency here, based on an article appearing in yesterday's Washington Post, I'm wondering why the District of Columbia had to pay back the federal government a grant of over $15 million since they missed a date for filing that was required.
Right. So just for clarity, so I'm the District of Columbia Housing Authority. Unfortunately, the entity that had to turn the money back is the District of Columbia Housing and Community Development Agency, which is the city's housing department, not the ones charged with public housing. I mean, I can't speak to that as I'm not charged with those funds, but I will say that clearly nobody wants to see money go back. I think that if there's any solace, the good thing is that money, well, it may have not been used here in D.C., would be repurposed and sent to other cities. So from a national community standpoint, that's one point of view. But I can't speak to it because it was not my agency, sir.
Another question? I thought I saw a hand over here. Yes, ma'am, back there.
In the past two panels, all of the speakers have spoke to urban communities. What is being done in rural communities, especially as our rural communities age, to help build healthy communities in rural ares? I'm
glad you brought that up. We had been focusing obviously on DC in this panel, an urban area. But does anybody want to? I can speak to that. Paula, do you want to speak to that?
So we serve D.C. and then all the way into Prince William County, Virginia. So we definitely have a big urban center. We have suburban areas, and we have some areas that we're reaching that are rural. So it's really interesting to think about. And one of the ways that we've thought about serving rural areas differently is we look at where rural pockets of poverty and food insecurity exist. And the first thing we do is, of course, we say, we look at the data and then we say, what is happening on the ground? So one of those kind of findings that we saw was that along the Route 1 corridor in Virginia, there was a lot of childhood food insecurity. And there were a real lack of organizations that were addressing it in a concerted way. And so this is a great example of our grocery partners. We actually had a conversation with one of our grocery partners, Shoppers Food Warehouse, and said, they're entrenched in Virginia, and we said, hey, this is something we'd like to take on. Will you fund it? And they actually helped us construct a mobile meals bus that goes down the Route 1 corridor and provides summer meals in trailer homes and other places that are disconnected. I know we talked a lot about little being bifurcated by highways. That exists in the service area that we touch. So it's about knowing the community and then building and being flexible enough to build a targeted approach for that community and investing in it.
And I'll say from a healthcare standpoint, one thing that that I and some of our colleagues participate in is a program called Project Echo. And it actually provides, we find that in rural areas, there's always some either a one-person doctor's office, which is often the case, or maybe a rural health clinic, maybe sometimes even a critical access hospital that's designated for a rural area, but they lack certain specialty care, and they often then have the challenge if someone has a diagnosis of cancer or something that requires specialists, that they have to tell patients they need to travel sometimes hundreds of miles to get that care. We're part, if you Google it, Project Echo, it's actually part of a very simple kind of training program that's done over video teleconference for 1 hour a week, where we actually have people teaching other clinicians in both rural and in urban areas where there's actually deserts of these providers, how to take care of patients that might require more specialty-based care, but for which you just don't have it because you're in a rural setting or you're in an isolated setting. And so there's a great number of these issues that translate both urban and rural opportunities. There was a question over here. Yes, ma'am, back there.
Thank you all very much for the information you've given to us today. I have a question. I haven't heard anyone speak about the need for housing for trafficked children. As you might be aware, Congress reported in 2013 that over 300,000 American-born children are being trafficked in our country. Washington, D.C. is considered by certain reports to be the second city with the highest incidence of human trafficking. Why aren't we doing something about this in terms of housing? There are only two organizations, Fair Girls and forgive me, another one, who provide services in DC to help house these children. Many of the reasons why these children do not come forward to the local police is because they have nowhere to go. Please, can someone address this? Thank you so much.
Yeah, so I think that one of the things that I know that DC does believe in is trying to find affordable housing solutions for the different populations that need it. In this particular space, there are nonprofit groups that we do work with, some of which I won't name because of for obvious reasons, but one that I will is Sasha Bruce. Some of you may be familiar with Sasha Bruce's work, and they have become a very safe place and a safe haven that even by word of mouth, a lot of our youth that feel challenged about entering the government sector, they're able to go, and it's a safe place for them. And there are other organizations like Sasha. We have a strong relationship with Sasha. I know other of my my government partners do as well. There's always more that can be done. Let me suggest that. I think that we just need to find a way that individuals feel that they can enter someplace and not be judged and be safe. And sometimes that's half the challenge, particularly if it's in a government space.
All right, I'm going to do the last question, and we're going to have a break, so if people who couldn't get a question in want to approach our panelists, we can. This lady in the back.
Hi. Yes, thank you. Paula, I know you had a principal role in improving the food that's available in DC schools. I'm wondering what the situation, I've just come here from the UK where I was struggling to make them appreciate that food in the NHS, make them appreciate that food is medicine. I found it very ironic that the patients who were there were being fed things that were not necessarily conducive to their recovery. So what's going on here with food in hospitals? Are you facing a similar situation to what you found in the schools?
Absolutely.
Maybe even a little worse, I would say. I'm not joking about it. I mean, I know that we did a kind of a canvas of the district area hospitals, and found that all the hospitals, the major hospitals in the district, and I don't think this is too dissimilar from other urban and rural, we basically vend out our food resources to a third party,
Right.
with which we have very little, like zero kind of, dialogue about nutritional input or output.
And I will say we haven't necessarily been involved in that, but from my personal experience, what I found is actually the same third-party food vendors that are serving hospitals are also serving schools, and they're also serving businesses, prisons. They're across the board. They have different names for their different sort of segments of their business. But it's really important to have conversations with hospital administrators around how can we contribute to health within the hospital itself. And certainly, I've actually been to meetings at hospitals where I've forgotten to have breakfast and literally all they have is donuts. So these are ongoing challenges. I know within the district there's a committee that's under the Department of Health called the Diabesity Committee. That contains a group of clinicians and folks who are associated with hospitals who are trying to make inroads on that front, and also around sugar-sweetened beverages and the proliferation of sugar and allowance of sugar-sweetened beverages in hospitals. So there's work being done.
I think, if I can say something, that we have not for our patients, but for our staff. Like, as of June 1st, if you visit the Sibley Hospital, you're not going to be able to get French fries. Like, they're getting rid of,
Right.
it's a wholesale nutrition
But that was
increase.
done, I know, Matt, that took effort to
Yeah, and
educate.
that's a Hopkins, my understanding is that's a Hopkins system-wide
Right,
thing,
right.
and it's been, it's going to be interesting to see how that
And people get
goes
angry,
over.
by the
Oh,
way.
yeah.
I mean,
Take
people,
their French fries? Come on.
are not, me being one of them sometimes.
Yeah, yeah.
People sometimes get upset about choices being taken away.
Right.
But it's to speaking to that lady's question about, how are we offering something that's healthier? So, I know there's more questions. We're going to have a little bit of a break just to stretch, bathroom, and then get into our final panel. Join me in thanking, I think, this excellent panel.